Так, наступний у нас Себастьян Блок. Колеги, включаємось. Хочу нагадати, він зараз про це, до речі, скаже. Себастьян Блок – це перший іноземний спікер, який приїхав в Україну і презентував можливості ультразвуку для анестезіологів саме в регіонарній анестезії. Це було далеких 10, 12, 13 років назад. Ми вже щось робили, зрозуміло. Вони думали, що ми нічого не робили, були здивовані, що ми вже щось робимо, але слід віддати належне, це перша людина, перший ганець з Європи, який сюди приїхав і розповідав, як треба правильно працювати. За цей час він тільки своєї майстерності набрав і зараз є одним із ведучих спікерів Європейської асоціації з регіонарної анестезії. Включаємось.
Hi everyone. First of all, I would like to thank the organizational committee and Andrei Strokan for this invitation. It's a huge pleasure for me to attend your meeting, your crash meeting. Unfortunately, it was not possible for me to come to you because I'm already in a meeting in France, a meeting dedicated to orthopedic surgery, arthroscopic surgery. Just about your place. I have an incredible souvenir. I went to Ukraine, to Kiev in 2008 for a meeting. I have clearly an incredible souvenir of dinner, meeting, sharing. The topic was to introduce ultrasound in regional anesthesia, and clearly it was a very, very good time. So my name is Sebastien Bloc. I work in a private establishment in Paris, in a private establishment dedicated to orthopedic surgery, le droit au sport et arthrose. And I will talk about the modern view of regional anesthesia for knee surgery. Just before, to discuss the different techniques we can use and we can propose to patients for knee surgery, and I will use the model of arthroplasty. Just few slides to introduce the reason why this model is clearly a very good model to discuss about analgesia after orthopedic surgery. Why is it a very interesting model? For three reasons. The first one, the characteristic of pain after knee arthroplasty. On this slide, you have two models of pain, two trajectory of pain after surgery. The first one after knee surgery and the second one after hip surgery. And as you can see here, the day after surgery, so in the early period, the level of pain is clearly higher after knee surgery than after hip surgery. It's the same for the duration of the level of pain is clearly higher during several days after surgery and higher than after hip surgery. So first, about the characteristic of pain, duration and intensity. And the correlation is the higher use of opioids in the postoperative period. So first characteristic. The second characteristic is the impact of pain in the pathway of the patient. Here you have two tables with two similar studies about the impact of postoperative period on the discharge of the patient. And if you look at the two reasons of late discharge, the first one is the level of pain. So you have a high level of pain 1, 2, and 3 days after surgery. And the second one is the muscle weakness. So this is you have the same result in both studies. So first, intensity and duration, and second, the impact of pain on late discharge, and also the impact of pain on muscle function, on weakness, on range of motion. So you have to find the right balance in between mobilization and level of pain. The third reason why you have to find the best technique of anesthesia and analgesia after total knee replacement is that acute pain could be a cause of chronic pain. So there is clearly probably a correlation between acute pain, transitional pain, and chronic pain. And this is a study that assess the reason of chronic pain. And as you can see here, in the group chronic pain after total knee replacement, in the group chronic pain, the level of pain the week after and the month after surgery is clearly higher than in patients without any chronic pain. That's The three reasons why we clearly have to find the best technique of anesthesia and analgesia after total knee replacement: the level of pain, the intensity, the duration, the impact of range of motion, and the impact of transitional pain and chronic pain. So I'll talk about the modern point of view and my point of view, and you will see that some of techniques are not clearly modern, but old techniques, and could be old technique. And the modern point of view is probably more to adapt your technique of regional anesthesia on your pathway. So here, we clearly have to find the right balances, as I explained just before. Right balance in between pain-free and the motor sparing blocks. So for pain-free blocks, you have the femoral block, the sciatic block. After femoral and sciatic block, patients are clearly not able to walk in the early period. You have to wait the recovery of the muscle function. And after motor sparing block, example, adductor canal block, triangle femoral block, IPAC, LILA, and we talk about genicular nerve blocks, clearly the patients are able to walk. But what about this balance? What are the most efficient in terms of pain and what are the most efficient in terms of deambulation? This is a very interesting study, recent study from a French team, the team from Philippe Marty and Alain Delbos, and they assessed two different modalities of anesthesia and analgesia after total knee replacement in 90 patients. The first one, proximal block, a quadriblock, sciatic, femoral, obturator, and lateral femoral cutaneous nerve of the tight. And in the second group, distal block, triangle femoral block, IPAC, and obturator nerve block. If we look here on the postoperative mobility and here on the pain score, as expected, with proximal block, patients are not able to walk the day of surgery, so you have a real motor block. But if you look here at the level of analgesia, so level of pain in the day after surgery, and you have the same with the consumption of opioids, is clearly higher in distal block. So proximal block are pain-free block, but without any deambulation, and distal block are motor sparing block, but probably with a higher level of pain after surgery. That's why we have clearly to find the right balance. One of the important messages, if patients are not able to work the day of surgery, example, no physiotherapist or not organization for early deambulation, you probably can use these old blocks that are very, very efficient. On the other hand, this is modern point of view of these techniques. These techniques I discussed about the impact on analgesia, but there is also an impact of anesthesia of this block. This is the same team, and they assess one adjuvant to improve the quality of analgesia after this quadriblock: femoral, sciatic, obturator, and lateral femoral cutaneous nerve blocks. And they assess two placebo and dexmedetomidine. But clearly the adjuvant is not very interesting. That is very interesting is that with this block, it's possible to perform the surgery in a awake patient. There were only 4 patients out of 90 patients who needs general anesthesia, so who need a conversion to general anesthesia. So if your pathway, if your organization is in favor of this technique, it's clearly adapted to a awake patient. And it's also adapted to fast-track program. When you see here the ability to patient of deambulation of stand-up D1 and D2, 100% of patients are able to walk. So these all blocks are clearly adapted to fast-track program if you use this block as anesthesia more than just analgesia. But probably the same for you. There is clearly a new paradigm in your country. We have this new paradigm in France. Every anesthetist switched from proximal nerve block to distal nerve block. As you can see here, this is a survey in 2017, and as you can see, 70% of anesthetists prefer adductor canal block than femoral block for a single shot, and there is also a very high, excuse me, there is not a high, it's clearly higher. The use of femoral block, proximal block, is higher when you use peripheral nerve catheters, but with a very low rate of catheter. Most of anesthetists choose single shot than catheter with a high level of use of infiltration by the surgeon. So we'll talk about this distal nerve block just to well understand that if you want to use it, you clearly have to mix different blocks to be efficient. Only one block is not enough. You have to perform several techniques. The first one is there a real difference in between femoral triangle and adductor canal block? Probably not, in my opinion. In this picture, you have here the modelization of the triangle femoral block. So when you can see the adductor longus muscle just under the sartorius muscle, you are still in the triangle femoral. When this muscle disappears, you are in the adductor canal. What is the reason? It's just because with the IPAC, you will block the posterior part of the knee, because we'll block here the different genicular branches from the two branches of the sciatic, the fibular and the tibial nerve, and also some branches of the obturator nerve. So in this article, the authors assess the impact of the combination of adductor and IPAC block instead of adductor and periarticular infiltration by the surgeon. And as you can see in this conclusion, when the surgeon performs a HELIA, it's really not necessary to perform an IPAC. You're right, but it's when the IPAC is well performed instead of a right infiltration by the surgeon. Clearly, it's better to use IPAC. And when you have no infiltration, adductor and IPAC improve the quality of analgesia. One very modern technique is to add a block for the superior and lateral part of the thigh, because with the adductor canal block, you will block the superior and medial part of the thigh, the lateral and inferior part of the knee. You will block with the IPAC some branches of the posterior part of the knee, but what's happened here in the lateral part and superior part of the knee, there's no possibility to block this nerve with these two combinations. You have a right efficiency with the femoral, but using only IPAC here and adductor, it's not efficiency. That's why here the author proposed to add a technique that is used for chronic pain, is a block of the superior and lateral genicular nerve. So you will block here and to add an efficiency in that part. And it's clearly very efficient in this study. And in your practice, this is one of the techniques we use. We perform IPAC for the posterior part of the knee. We perform saphenous nerve block and vas medialis nerve block, performing triangle femoral nerve block instead of a real adductor canal block. So you will block this part of the knee. And with the genicular superior and lateral genicular nerve block, you will block this lateral part of the knee. And in that way, you probably have a good, not as efficient as femoral and sciatic, in my opinion, but clearly more efficient than only IPAC and adductor canal block. And this is, to summarize, one of the very interesting conclusion is that to be efficient, you have to combine nerve blocks. Nerve blocks by the surgeon, LEA if you want, nerve block by anesthetist, proximal one if you want to combine anesthesia and analgesia, or distal nerve block if you want to just have analgesia. And if you want to have analgesia, you clearly have to combine most of possibilities to cover most of nerves that supply the knee. Triangle femoral nerve for saphenous and vas medialis, genicular, superior and lateral, and IPAC for the posterior part. And just to highlight that multi-nerve blocks are clearly more efficient, this is a study that compares different kind of block, but clearly the different kind of block is not very interesting. What is very interesting? is that one infiltration by the surgeon is efficient, very efficient, but just a very short time, no more than 8 hours. 4 blocks by anesthetist, it's good for 24 hours, but with a risk of rubber pain. And when you combine two techniques, ear femoral and peri-articular infiltration, clearly you will be more efficient about intensity and duration. So the main message is clearly to combine the different blocks. Two other very interesting and important things. Continuous nerve blocks, so catheter, are clearly very efficient. Femoral or adductor canal or triangle femoral nerve block, nerve as you prefer, but it's efficient, and it's also efficient for very early discharge. This is an example of patient for unicompartment knee arthroplasty, and patients are in day surgery, so it's possible. You just have to give to the patient the right education with prevention strategy, immobilizer, crutches, education of the patient, education of the environment. So everything is possible. It depends on the possibility you have to give the right information. Other very interesting thing is that to avoid the chronicization of pain, to avoid the transitional pain, it's clearly very interesting to use this block, this rescue block. This is an example of two different kinds of block, femoral nerve block and adductor canal block. And as you can see here, using this block, when the patient has a severe pain, if they have surgery, you will decrease the level of pain. And using adductor canal block, you have a real motor sparring block, so no impact on muscles. So it's a very good technique. If you use proximal block the day of surgery, use the day after to in case of rubber pain, use distal nerve blocks that are as efficient and that has less impact on motor function. So to summarize, the best option, it's, in my opinion, the modern point of view. It clearly depends on your organization. You have a lot of possibility to block or to give the right anesthesia and right analgesia, and you have to choose the best one depending on the hospitalization modalities, day surgery, 2 days, 3 days, 5 days, and the possibility to perform rescue block. So it depends also of the length of stay. It depends on the early mobilization. If patients are not able to work the day of surgery, you can use proximal block. If they work just the second day of surgery or the third day of surgery, femoral nerve block are clearly very, very efficient. It depends on the information and of the education of the patient. Thank you for your attention.
Так, дякуємо Себастьяну. Шановні колеги, знову ж таки, якщо є питання, будь ласка, ми напишемо, Себастьян відповість, у кого є запитання, але що хочеться підкреслити, що в даній ситуації світова тенденція в просунутих клініках іде до того, що пацієнти після ендопротезування коліна виписуються ввечері, після оперативного втручання. Да? І мета анестезіолога зробити так, щоб пацієнт поїхав додому, йому було не боляче, і не боляче було ще досить довгий проміжок часу. Тому і питання про катетери, особливо стегнові, стає дуже актуальним.